name's Professor Gareth Morgan. I'm at the Royal Marsden Hospital in London, England, where I head up the Hemato-Oncology unit. So I'm here at the American Society of Haematology meeting presenting the results of a genome scan aiming to define prognostic subgroups of patients. This is a novel approach to this question, where we've mapped regions of gain and loss of the myeloma genome on a group of 100 odd patients and defined regions of homozygous deletion. We've then looked within those regions of homozygous deletion to identify the genes where there's an altered expression, and so we identified maybe 170 homozygous deletions, and for the ones that occur frequently we were able to look at their prognostic impact, but nothing really occurs much more than a frequency of 10%. So it's very difficult to look at the prognostic impact of that. So we used a bioinformatic algorithm to look at the 170 genes in their entirety and defined a cell death deleted signature where changes in cell death genes were important, and the reason they were important was because they defined 20% of the total group that had an inferior prognosis. Well, currently you can't really generalize that to the greater group of myeloma because there's just not the gene mapping data. So we used this data set to train an expression profile based on global gene expression, and we had a 90 gene signature, and using this 90 gene signature on an expanded cohort of patients we were able to define again approximately 15% of patients that had an inferior prognosis. Again, it's alright doing it in one data set relevant to the UK, but then you have to validate that in another data set. So we validated it against John Shaughnessy's total therapy treated group, and again we identified a poor risk group of patients, and then we again looked in a well-cared group of patients at relapse, and again the signature validated. So we have a worthwhile signature that identifies maybe 15 to 20% of patients who have a poor prognosis. This is important because you can treat this group of patients differently. And so then again, from a patient perspective, you don't want a global gene expression signature that you can't have done on yourself. So we were trying to make a more limited signature based on something that you could actually measure regularly in the clinic. And we minimalized this signature to the ratio of 3 pairs of genes. And using this 3 pairs of genes, we're able to, again, to identify this group of poor risk patients with high sensitivity and specificity. So our aim now is to take this forward into the clinic and then use it to identify groups of patients that will be suitable for treatment approaches that overcome this signature.